I'd like to introduce the rest of the panel. Some you've heard from today, but not everybody. We've got Professor Martin McCabe, who is a Professor of Paediatric Oncology here in Manchester. You've already met Simon Kenny. We've got Dr. Peter Sharples, who is a consultant neurologist from Bristol and is very passionate about this area in children's neurorehabilitation in general. You've already met Dr. Simon Owen, our consultant endocrinologist from London, and Claire Finch, our very passionate parent representative who you all met this morning. And last but not least, we've got Claire Strong, who's a really experienced nurse specialist from Sheffield and a real advocate for patient needs. If we can start off on this topic of children's neurorehabilitation services, perhaps one that Dr. Sharples and Professor McCabe can speak to first. But why is it at present that a lot of children with brain tumours who clearly have a form of acquired brain injury are not receiving the rehabilitation services that they require from the beginning?
So I must say this is not my area of expertise, and I did not prepare an answer to this question. Firstly, I think that there are many children who, at the point of diagnosis or after their surgery, don't need necessarily neurorehab, who actually have a successful operation and are very well after it. And then there are plenty of children who have neurorehab starting at the point that they're first seen, because there are obviously major problems. Where we struggle in clinic is, and on the wards, is with really a lack of staff, but also possibly a lack of evidence. There may be very good evidence in the paediatric brain tumour world that starting neurorehab at day one is very effective, but I'm not aware of that evidence. And there are plenty of challenges in the first few months of treatment that might really get in the way of effective neurorehab, particularly if you're on ICU for several weeks. You're not going to be able to do a lot of physio, or if you're having a lot of chemotherapy and radiotherapy, it's very difficult to fit rehab in. What I would like to know to answer that question is, what is the evidence that it makes any difference? There's clearly a problem with funding, that there just isn't enough money in the service to sort of have all of the therapists that we need, and that's very evident to any parent or staff who works in the service. But if we're going to, we live in the world that we live in, and if we're going to persuade commissioning that this is critical, we need to have very strong evidence that it makes a difference, or at least be developing that evidence. And I don't mean in children who've been involved in a car crash, but I mean the very complex mix of children with brain tumours who have all sorts of other things going on in the first few months.
So for acquired brain injury as a group, and I totally take your point about the particular complexities about early brain tumour rehabilitation, there is unquestionably evidence in adults that early neurorehabilitation is cost effective, and it's cost effective in an 18-month period. There's also evidence in children from Nottingham, again looking at the entire brain injury population, that you can recoup the costs of providing a specialist neurorehabilitation team within a year, so that you can basically make the team pay for itself. So I think the evidence actually is out there, and that we can afford to do this, but we've got to reorganise ourselves. I totally take the point that there are complexities about early rehabilitation for children with brain tumours. We do manage that situation in my centre. We work alongside oncology, when they're delivering radiotherapy, chemotherapy. We're trying to do neurorehabilitation in the afternoon when they're not having these therapies. And we also have a system, if a child becomes too unwell, to actually engage with rehabilitation in the early weeks after diagnosis, that they will admit them electively at a subsequent point when they're more medically stable for further rehabilitation, and we've shown that can be effective. So I think there actually are things we can do, but it's going to require services being reorganised, and it is going to require some upfront funding, although I think it'll pay for itself.
Professor Kenny, is there anything that you'd like to add to that?
No, I think so. I think in terms of evidence, it's about going to the specialised neurosciences, CRG, putting the case forwards, and then that will go through and the evidence will be examined.
And you mentioned the strong patient voice being important.
Yeah.
Could you give any, you've got some very passionate families here today, of which Claire is one. I don't know if you have any questions about some. A question I'd like to ask you.
Yeah.
Go ahead now.
But we sort of really everything we do, we have patient voice in. In the Children and Young People's Transformation Programme, we've got 6 young people on our board. So the voice is really important.
So I've got 2 points that have been boiling, I feel I would like to say is, I work in the charity sector, so I'm used to working with very constricted funding and helping other organisations to work with that very constricted funding. But one of the things that we always do, because our funding is very restricted, is we get evidence for everything that we do. And my question genuinely is to everybody here, even some doctors in this room that I really, really respect, is why? Why haven't you got the evidence? Why aren't you speaking to the parents? 6 children out of all the children with brain tumours is not evidence. And I guess I'm suspecting that those are the kids and those are the young people that are well enough and in a position where they can speak and advocate for themselves. So why are you not getting that evidence? Because we're here, we're willing to speak, we do speak, but nobody listens. So that's where I feel very, very strongly, and I'm sorry if I sound very angry, but I am actually, and I'm fed up of saying it to people all the time, and I'm glad you're here, because I want you to hear our stories and hear our evidence, because it's really important. And the other thing is we've had to make very difficult decisions as a charity as to where our funding goes. At the same time as my son was released from Manchester Children's Hospital into care in the community, which that statement alone is a joke, my friend broke her little finger. She got more physio and rehabilitation for her little finger that she broke during a netball match than my son did coming out of brain surgery, radiotherapy and chemotherapy. So I think we have to start challenging, and some of those are your colleagues that you're going to have to start challenging and ask, why does an adult woman in her 40s get more physiotherapy than a 9-year-old child? And we talk about the cost-benefit analysis. The cost of Adam not having that rehabilitation, the cost of Adam not having that support earlier on is costing a lot in the system and will continue to cost a lot in the system for the rest of his life. Sorry.
So can I apologise if I sounded complacent about the 6 children? That's 6 children for the Transformation Board, which is a sort of large-scale thing about where we're going with children's services overall. But what I would expect is that any policy proposition that's going forward to, because there's mechanisms, I've shown you what the mechanisms are, what we would expect is that there's a really strong clinical parental voice and child voice in that. And that's really important, and those stories are really important. I'm not undermining you in that respect.
Let's stop
Yeah.
making excuses and let's say,
Yeah.
the evidence is here, we can gather it.
And what hopefully I've done is given you the route map that shows you this is the way to affect change.
Professor Kenny, can I ask you, we've seen transformation projects, I mean, I've been peripherally involved in the SCI one, that have been very effective drivers of change. Do you see any possibility at some stage of paediatric neurorehabilitation being adopted as a transformation project?
We can, which is why we've got a national specialty advisor sitting there. So you look, there were some other specialties which have got their own pressures, like rheumatology, like respiratory. They don't have a national specialty advisor because we know that there is an issue there. What we need is we need the evidence, and we need the support of groups like this to get us across the line in terms of delivering that. And I think the other issue, and it's sort of, I've sort of been on a journey as a surgeon myself, moving from treating the patient in front of me and trying to do the best for them to suddenly stepping back and looking at both the whole pathway. Why did my patient how did they get there? And then what happens to them? And then more laterally to what happens on a population level. And I think that it's thinking in that wider context as well is incredibly important.
Thank you. Can we just drill down, 'cause it's incredibly helpful to have you here, on this idea of evidence and the type of evidence that you think will be effective? I presume you're talking about efficacy of interventions rather than case studies that we have today, alongside the strength of parent voice. What sort of evidence do you think counts? What do we need to gather?
So there's numerous examples I can think of that are not dissimilar. I suppose the sort of one which is sort of quite current at the moment is surgery for children with chest wall deformities. So children who've got pigeon chests and pectus excavatum. And that the community there were saying we haven't got a service, and we really think that the evidence is there. And we've been through several cycles with that, of it basically examining, well, what would the evidence be? And so we're examining the evidence from a psychological, equal parity in terms of psychological and physical outcomes, but also looking at wider outcomes such as school attendance, employability, and things like that. And in that, the evidence wasn't there, and so and a lot of frustration for the surgeons and the children and parents who are involved in that. But by saying that, it's put them into a position where they know what to do, and so now there's studies going on that are looking at those specific things. We've already started to commission some of the services where the evidence exists, but it is very so it's quite quantitative, the evidence that's needed, but it's not. It doesn't particularly need to be, data around well-being is given equal weight as physical outcomes, and I think for all of us, actually, what we'd want for our children is that they achieve the best they can, and that is probably looking at school attendance, well-being, and future employability.
Thank you. I think one of the challenges, certainly as a psychologist, is some of the benefits of our work are incredibly difficult to measure, and they're hard to measure in the way that you might over some more concrete interventions. I am keeping an eye on time for you. I'm aware that you need to leave. Is there anything anybody would like to ask Professor Kenny before we let him go?
Thank you very much. I couldn't let this opportunity go. You hinted at it. You said children with cancer cross brain tumours, cross so many different CRGs, funding issues. And I think that's the area that I've come to decide. If I did have 1 million or billion, which specialty would I give it to? And that's been my problem. I'm an outsider, I'm an endocrinologist, and we have tumours that are in the pituitary that I think should be highly specialised because they're only 10 a year in children, and there are consequences of brain injury that I've realised are not treatment related, although we thought they were to begin with. They're actually due to the location of the tumour in the brain. We've perfected surgery up to a point, and we're specialising. As you say, we need to specialise in new techniques, but we're in a position where children with pituitary tumours don't get the same pituitary tumour service or endoscopy. We're not running research. We haven't got the data to prove it, but if we could concentrate them in 1 or 2 centres, we'd begin to get that data, as they have for retinoblastoma and other rare diseases. But we went to the cancer APPG. We tried to get, I didn't have enough arms to go to the brain injury APPG. We're lobbying of sorts, we're trying to learn, but which of these CRGs should we lobby? And is it that oncology now is so concentrated on oncology that actually we ought to be combining forces with neuroscience and we should be crossing and thinking about how we can rationalize that funding? Because it seems to me that there are centers who do have brain injury support and others who do not. And that could be part of the explanation.
Yeah, you cannot have an ideal structure for everything. Arguably, I think cancer services are too focused on primary diagnosis and not on the rest. I think that's sort of probably increasingly recognised. I think in terms of where to sort of go to, I think it is. I would go to the Women's and Children's Program of Care and the Specialised Neurosciences group, because that's where the concern is starting to concentrate across different reasons for having an acquired brain injury. That people talk to each other. They all sit on the same floor in NHS England. So it's not impossible to work across those boundaries. But whenever you get divisions like that, it worries me. I think that you get people thinking, well, I've achieved my metrics for this. I'm not that worried about that. But I think that's where the patient voice is really important, because you then, when you start hearing the stories, and when commissioners start hearing the stories, they change. Suddenly the scales come off and they realise what the problem is.
Thank you very much. Very aware you had to go. Thank you very much. We'll let you go, but thank you for coming today. And we will continue with our panel discussion. I think we're running slightly over, so can we keep running on the panel discussion? Yes. Dr. Sharples, could you tell us a little bit more about how you're managing the problem of neurorehabilitation in Bristol? Because this is something you've been working on, isn't it?
Yes, thanks very much indeed. So we had a regional working group over a 2-year period, 2004, 2005, which was set up actually by commissioners, but it included clinicians from a multitude of disciplines relevant to neurorehabilitation from throughout the region. And the reason for having this group was that commissioners had appreciated, as a result of some patient complaints, and that just shows how powerful the patient voice can be, some parent complaints about ABI neurorehabilitation services, that this problem needed addressing in the region, because we did have an inpatient service, but it wasn't specifically funded at the time as a service, and we had problems when patients were discharged with getting them services in the community, and the handover and step down aspects of care weren't funded or provided. So we came up with a regional model, which I now know from experience of other regions adopting a similar model, works not just in the southwest, but in places like the East Midlands and the southeast. And that was to have a hub and spoke model. So you've got your specialist neurorehabilitation team based in the regional science unit, so that they can start delivering rehabilitation while the patient is still acute, even while they're still on PICU or high dependency. And then you have a period of post-acute inpatient neurorehabilitation. And then you have step-down outpatient neurorehabilitation. And what we eventually want to provide is a more secure system of outreach neurorehabilitation to patients who can't come back to our hospital for outpatient rehabilitation because they live too far away. So how do we provide ongoing specialist input for them? So we've partially develop this model in terms of funding. So we have a dedicated neurorehabilitation bed day tariff now, which provides approximately twice the funding that most centres get for inpatient neurorehabilitation, which is based on a long stay bed day tariff, according to which neurology or neurosurgery diagnostic code they came into hospital under. We have funded a step-down outpatient pathway so that patients can be discharged from hospital as early as possible once they're medically stable, but can still come back to us for rehabilitation. And as I say, we're currently working on the sort of wider outreach service. So I think that this model is now working in Nottingham, King's College, Southampton and Oxford. And talking to colleagues at the UK Neurorehabilitation Network, which is the BPNA Neurorehabilitation Special Interest Group, they feel that this would work for them if they have that additional funding. So that's the case that the CRG for neuroscience are trying to get across the line. The idea that there's a revised service specification for neurorehabilitation that states you should work it on a hub and spoke model, that states you need funded inpatient services, but you also need outpatient and outreach services. and that, you know, that's mandatory if you're a regional neuroscience centre. But because that's going to cost several additional million over what's spent on these children at the moment, the CRG is trying to get that over the line, and that's where Professor Kennedy was saying that, you know, the support of this group and other charities be hugely helpful. Sorry, Martin.
I mean, I think it's fantastic what you've done, and the talk you gave earlier, you showed some clear metrics that said things had improved. I mean, the Southwest is not the only geographically difficult region. Here we have children from, say, Millom, which is at best a 2-hour journey each way and might be 3 hours, depending on the joys of the M6. So for those children, it's just not feasible. And some, you know, some of these rehab needs go on for the whole of their life. So giving them a week of intensive physio is not going to do the job. I haven't actually got to the question yet, which is now going out of my mind. So you demonstrated very nicely some good metrics, and if that service could be delivered locally, hopefully those metrics would continue. Would you say your children and parents are happy that all of their needs have been met by that model?
Yeah, so the ones who, no, I don't think it's all lovely in Bristol and the Southwest. I think what we've got right is the early part of the journey. Well, with the two things we haven't got right yet, we're not delivering an equitable service for the children from Devon and Cornwall because they can't come back to the step-down outpatient service. And we're also not very good at delivering the long-term care that's needed. So there are a number of ways you can do that. So what the outpatient model, the outreach model that we're beginning to work on is the idea that you have a supervision and training from the specialist centre, but the care of the individual children in Devon and Cornwall once they leave our inpatient unit is delivered by local therapists. What it can't be is delivered by community-based therapists who are unfamiliar with acquired brain injury and feel overwhelmed by the task of providing this, and who also haven't got enough time in their job plans to provide an adequate level of service. So the model we're looking at, and in fact commissioners have already started inventing this in some parts of the region, is that you employ a specialist, for example, speech and language therapist they have in Cornwall and they have one in Bristol, somebody who covers several sort of community teams patches, but all geographically adjacent, who has specific expertise in acquired brain injury and who works closely with the therapist, speech and language therapist from the centre. And there's a model for that with speech and language. There's also a model for occupational therapy. So I think actually the commissioners are beginning to invent this themselves. It seems to be working really well. So the piece of work we want to do is to actually, sort of get commissioners together and say, can't we make this something that's happening throughout the region? And the other thing that the revised service specification will say, if it eventually comes out, is that patients should be reviewed on an annual basis at least by the multidisciplinary specialist neurorehabilitation team, and that will give us the opportunity to find out if there's gaps and start flagging them up, and eventually more funding will be needed, but we need a bit more evidence of the gaps, and that clinic will provide it.
Thank you, Dr. Sharples. I want to come to Claire about service in Sheffield in a moment, but before I do, I know that Dr. Alwyn has to go in a minute. We wanted to ask you a question before you do about pituitary tumours, which are incredibly rare in children. And I understand that pituitary surgery is centralised to specialist centres for adults because the outcomes are better, but we're not doing this in children for whom damage to that area could be much more important, potentially one could argue, to their future life. Could you comment on your thoughts on that for us?
For sure. And I let it slip at the beginning that today is one of those days that is an important day for me, so I do have to get back to my household. I've really enjoyed today. Thank you very much. But so there's been some incredibly inspiring discussion, and I have to say I'm going away with a deep appreciation of the sort of much bigger world of neurorehabilitation and how it affects the patients that I have, because I look after the craniopharyngioma side of the pituitary spectrum and also the endocrine aspects of the late effects with other brain tumours. So today I spoke to you about a minute area of endocrinology, which is very much more about expertise. Now, Actually, the premise of the question is good but mistaken, because we are not any better at consolidating services in addict endocrinology, and I wonder whether we might actually be less good. I was actually was part of the endocrinology specialist services CRG, and in fact, I noted that it didn't exist in the original map that was put out. I've also had the experience of taking a proposition for a drug through the process, and what looked like a complicated process there, that is a top-line summary of what it actually takes. I'm in 3 years, and I've got 1 more year to go, and that's for a drug that's an incremental value to it for about 10 people that doesn't even cost any more than the one that it's going to be replacing. So it's a massive undertaking. However, I think this needs to come from the collective opinion of the advocates for the patients, and I think craniopharyngioma is probably, I can't talk for brain tumours, but for the pituitary and hypothalamic tumours, I think craniopharyngioma is a really key one, because the paediatric services are the commissioners here. They are the ones asking the neurosurgeons for the best that they've got. And they get to kind of choose, and they don't have to spend every week sitting, with their neurosurgical colleagues, if you understand me. When it comes to adult Cushing's, there have been so many conversations in the adult endocrinology world about trying to contract services, and everybody agrees that they want to contract services, but just not their one. And so they're very, very happy to keep it going. And then, of course, it's like, well, the patients don't want to travel very far, and then this and that and the others, umpteen excuses. But it is in some ways perhaps a little bit harder, because it's perfectly reasonable for the 22 or 27, I forget the number, neurosurgical centres to be doing some pituitary tumours. So non-functioning pituitary tumours can present relatively acutely. The outcomes might vary, but they're not varying from complete catastrophe to absolute success in anything like the same way. And so pituitary Cushing's gets sort of lumped in there with that, and it's quite difficult to work out what should be a highly specialist service, which it probably should, and what should be a regionally commissioned service, which it probably shouldn't for Cushing's, but it probably should for pituitary tumours. It's quite difficult with the adult world. In the paediatric world, there are just not that many tumours in the cellar and suprasellar region per annum, and there's really only about 4 there's a cranio, germinoma, some pituitary tumours, and then some bits in that sort of area. Now, there are other tumours that affect the hormones, but they're not sharing the key critical thing, which is the surgeons taking that on have to be adept at transphrenoidal surgery, craniotomy, and mini craniotomy at the same time. 3 different routes into the cellar, and that's what connects those things. So I think that you take and when you have those, it's got to be somebody who, and the certain neurosurgeons have got to be neurosurgeons who are using those routes into the brain a lot. Doesn't matter if it's 8 years old or 68 that much, I don't think. And so that's why I showed on my slide my view, the way that we did it, reasonably effectively, I would say, which was to say, okay, we need pediatric endocrinology for sure, but you guys need our rather deeper understanding of the nuances of endocrinology. So how does that work? That works really well, right? Because you understand a lot about puberty, and we understand a lot about the fine points of Cushing's interpretation. In the surgical side, adult neurosurgeons, if they are operating in the pituitary all the time, are going to develop a skill set that is quite specific. But you also want the neurosurgeons who are dealing with pediatric patients involved as well, because they just got a broader perspective on what children are about, perhaps, and the different aspects of neurorehabilitation. And that joining up those 2 things together is great. And they both really like it, because they're sharing their risk, they're sharing responsibility, and they're doing the bit that they're good at. So I believe that as a paediatric endocrine community has to find its voice in saying, this is roughly what we want. And if you can say, this is roughly what we want, collectively, then that's the beginning of a process that can become a decision to commission a specialist service in that area. I mean, it's going to be supported by charities, but it's not going to be driven by them. It's going to be, they're going to be asked to provide comment, and they're going to be asked for stakeholder analysis, but they're not going to be the one that's going to go to it has to be a clinician who goes to the specific CRG, or all of them, and says, I want to start a policy proposition for this particular service and collect it together. And by the way, 85% of the paediatric endocrinologists working in specialist centres agreed with these 6 points. Now, do we have something to start with? And I think that's probably the way to start building it up. Does that answer the... I tried to be brief. Thank you very much. I'm going to shoot, but only because the train won't wait for me.
Thank you. Super. Thank you very much to all that, Alan. That's really excellent advice. We're very grateful to you today.
Why don't I just let anybody come back at me for first of all, and then I'll kick off.
Does anybody want to come back at Dr. Alwyn?
Thank you. I'm a paediatric endocrinologist in Leeds, and I've had 2 patients in the past year who've been diagnosed with Cushing's, one of whom I'm really struggling at the minute to actually get the process moving for getting her to the right and relevant places for the neurosurgery. So I just wanted to say thank you, because I think that's really relevant. And I've spoken with Helen, and I've spoken with Helen's store in London, and yeah. I was going to say, can I email you? Because that would be fantastic. I'll ask Helen for your email address. Thank you.
We've been running this voluntary service, advisory service, which has no formal constitution from Great Ormond Street. We have a mix of different trying to access different specialties. We have a lot of people calling in. There's a great demand. We have one neurosurgeon from Queen's Square coming across. He has to operate on a paediatric neurosurgical bed, and they're waiting 4 months. So I think there is a need to actually make sure that the funding comes to the right people, and the right people can advocate for these children and pick them up afterwards.
Thank you very much, Dr. Alwyn. So we are running a little bit over, but I've just got a couple more questions for our panel members who've taken the time to be with us today, for Claire and Claire. Claire, building on from what Dr. Sharples was telling us about in Bristol, can you tell us a little bit more about your neurorehabilitation service in Sheffield, what you feel is working well and what you think you need more of, where the gaps are?
So I think from listening to everybody today, it's quite apparent that services vary greatly across the country, and there are huge gaps, and we need to look at how we address the gaps. So in Sheffield, we probably work a little bit differently. There is neurorehabilitation set up from the beginning, but certainly not to the extent where there's a whole team like there is in Bristol, and that's certainly a model, I think, that needs looking at across the country, so that we're all the same and there isn't the gaps in services. So in Sheffield, we work a little bit differently. We're lucky that we have Paul, our neuro-oncology outreach nurse specialist, who are with the families from the beginning during the treatment, but he also remains heavily involved post-treatment and helps families access the services they need. I know in some centres late effects isn't kind of introduced till a bit later on, but again we work a little bit differently. I do all the endocrine follow-up for our patients, so if problems are identified, I'm involved earlier. I'll do all the hormone testing for them, all the growth hormone starts. But again, even in our services in Sheffield, it does vary because we're only involved with the patients with malignant brain tumours, so the benign patients probably don't get the same service. And we know, they have as many issues as our malignant brain tumour children from a acquired brain injury point of view, and I think that is something that we really do need to look at in Sheffield. And also, things do start to fall apart a little bit post-transition, even though we put a lot of work into the transition process. There isn't the same services on the other side. Myself and Paul both act as key workers for our patients, but that key worker role is lost on the other side, and having that point of contact and who to contact with issues is lost. So we would love a consultant-led neurorehabilitation service that we've heard about today. I think that would work really well. But again, it should be, if it could be a pathway that could be used across the country, not just in certain areas, that we could all follow, that we were all doing the same things, and then hopefully there wouldn't be the postcode lottery and everybody would get the services that they deserve and need.
Just say, so from sort of like the low grade bit, so my role sort of like kind of developed over the years, and I tend to pick people up I shouldn't do and get them for it. But I picked up a lot of sort of like the low grades and some of the cranials I'm just trying to start to pick up now. But the problem is that I run a clinic, I run a virtual clinic, which actually goes through all the education, it goes through sort of kind of the physical stuff. I'm able to refer into our kind of physios and OTs that are part of our neuro group. The place where it fails is that once they've done their assessment and they send it into the community, there's not a supporting community.
Yeah, and that's what...
Because the lack of staff and they haven't got the time. So although I can pick up things, it's like, where do I go from here? Because I can pass it on to the Sheffield team. It's the community team that's sort of like that.
Yeah, and that's what I wanted to mention actually, Paul. Thank you, because I've forgotten about that. Is we can make all the referrals in the world, but if the services aren't there for us to refer to with the specialist knowledge, and as you say, I think a lot of the physios in the community, once they see acquired brain injury, brain tumour, I think they go into panic mode sometimes, to be honest, and then nothing gets done.
In fact, some community services actually acquire brain injury. That was the case in Western until recently.
Martin, you had a question?
Well, it's sort of related to the community services that you know, we work in a probably speaking to the consultant deputy. You know, we live in a world where there just is not enough money and not enough staff. Frequently, if somebody, say, years out from treatment for a brain tumour and they're still really struggling, let's say with physiotherapy, which at least is easier to deal with than some of the really difficult sort of symptoms like, you know, nausea and things that just go on for years, we refer to community and they say, well, there's no potential for further rehab because they've reached the best they're going to get to. It just feels wrong. It feels like if this patient was having active input, surely their lives would be better. How do we deal with that?
There is a model, and then there's these models exist in adult practice as well, which is you'd have a goal-setting meeting with the family, you find the young person, you find out what it is they particularly want to do that they can't do at the moment. You scale that down to make sure it's realistic, because it may start right up here. But you say, well, what we need to do first is this bit. And then you put together a programme of, usually in neurorehabilitation practice, it's 6 weeks or 12 weeks of input. And there are ways that you can make the impact of that last beyond the 6 or 12 weeks. One is by training up the parents to continue to supervise whatever the neurorehabilitation strategy is. And the other, some of us were talking at one of the breaks about the use of personal trainers, and I've had families who've employed personal trainers who are supervised by the physio and who can go on working with the young person after the physio has had to butt out.
And does that make a difference? Yeah.
We could talk about, very quick question, because I'm aware we're running over time, Benj. I want to come back to Claire as well before we finish.
Yeah, well, I'll just come back to what you were saying, please, at the end. So I'd just like to just very quickly move this onto postcodes and regions, because if a child is cared for in one region but lives in another region, what are we doing about the fact, and we talked about this earlier on, Paul, what are we doing about the fact that actually we're assigned Paul as a community nurse, but he's not within our region? What do we do about the fact that when we're talking to endocrinologist, neurosurgeon, we're talking to neurodisability, and they're looking at the options that we're entitled to, but they refer us to somebody not in that region, but in the region that we actually live in, and nothing is done. No one calls us. No one sends a letter to us. No one actually refers us into a service that our children actually need, all because we cross over an imaginary borderline. Do we actually realize what this does to a family? What it does to a family, and I'll tell you right now, if you want evidence, I'll give you the evidence, because I've lived it for the past 3 years. It pushes a family to the edge of catastrophe. And yet that's all to do with a borderline. This is madness in 2024 that we're actually at this stage. So I guess my question here is, how are we going to actually overcome the fact that this care falls down purely based upon where somebody lives?
Would anyone from the panel like to comment? Peter, thank you.
I mean, it absolutely shouldn't, and it's absolute madness. And what you need in that situation is a professional group who own that sorting out this problem is their responsibility. And I would say that is the neurorehabilitation team. And I have been in very difficult discharge planning meetings with all sorts of different people who've put up all sorts of reasons why this child can't have this, that, and the other. And I've become extremely experienced at battering them into submission, and I'm trying to teach the other consultant members of my team the same tricks, and they're getting very good at it. But that's what you need. You need someone whose responsibility it is, who sees themselves as the person who somehow is going to fix this. And my discharge planning coordinator now is becoming extremely expert at battering commissioners, so he don't always need me now.
Somebody who's actually going to take ownership,
Yeah.
rather than it just pushing.
Yeah,
It's
yeah,
not my
yeah,
problem,
yeah,
it's not in my
yeah,
region.
yeah, yeah.
It's a consultant.
Yeah.
It needs ultimately there to be a consultant, but as I say, people like the discharge planning coordinator, if they're empowered by the consultant, can get quite a long way.
Thank you, Peter. Claire, I'd like to give you the last word on our panel discussion, because I know it will be a powerful one. Would you like me to ask you a question, or have you got something you'd like to? I thought you might have. I had a question prepared, but I thought you might rather have something to say yourself.
I know that we've all been very passionate today when we're talking, and forgive us if sometimes we seem that we won't get down off a point, but I think it's because we've spent years hammering away at these points, and people listening, people caring, but nobody who's a change maker is making any difference. We talked about, you just talked about like, what are their goals? And I think perhaps if I just share this story with you about Adam, maybe that will realise what little we're asking for. When Adam was asked, first of all, by his physios in the hospital what he wanted to do again, at this point he couldn't walk, he couldn't use his hands, he had right-sided paralysis really at this point. He said that he wanted to jump again. So this was an ambition that was there for Adam to jump. When he went to the adult rehabilitation unit the other week, things have deteriorated so much, and the lack of support and the lack of help that Adam has got. He said that he didn't want to be in pain anymore. He didn't want his back to hurt every day, and he wanted to be able to stand up. That was it. That's his ambition now. His ambition is that he can stand up and have a conversation with people and not have to sit down. And his ambition is that he's not in pain. And he's 17. Where is it going to go? We have to get things centralised for people. You have to speak up. Parents, we will all back you, but you're the ones with the power. We don't have the power. We've got the voice, but we haven't got the power. So please help us, and we will back you all the way.